Okay. Okay, so we'll go through this tonight. SLAC wrist, SNAC wrist, post-traumatic OA, inflammatory OA, a bit about STT arthritis and primary OA. Okay, guys, just stop me anytime you want to ask questions, especially because we're going through the different topics. So if there's a question on a specific topic, then just stop me and we can chat about it there. Or if you want to save it for the end, that's fine as well. So SNAC stands for scaphoid non-union advanced collapse. SLAC is scapholunate advanced collapse. The classification was originally done by Watson and Ballet in 1984. So the top row is SNAC. So the first stage is where you get arthritis developing between the distal scaphoid and the radial styloid. Stage 2, then the arthritis develops between the distal scaphoid and the capitate, basically because the capitate starts migrating proximally. And then stage 3, it comes even more proximal and you get arthritis between the lunate and the capitate. And then stage 4 is pan-carpal OA. SLAC is slightly different. So stage 1 is pretty similar. It's between the radiostyloid and the distal scaphoid. Stage 2 is where it spreads to involve the whole scaphoid fossa. And then stage 3 is similar to SNAC, where the capitate migrates proximally and you get capitolunate and scaphocapitate OA. And then stage 4 again is pan-carpal OA. So this is just sort of a recap. So stage 1, radial styloid, distal scaphoid. Stage 2, scaphocapitate. Stage 3, lunocapitate. Then with, importantly with scaphoid is that if you have a scaphoid non-union, it will eventually progress to SNAC wrist. And that can be anywhere from 5 to 40 years. So sometimes patients only present at the age of 65 with a SNAC wrist, and they broke their scaphoid when they were 20 playing rugby, and it took 40, 50 years to become symptomatic. SLAC wrist, the difference with that is it doesn't always progress to SLAC wrist. So it doesn't mean you have to always treat it. And it's not quite clear exactly why some patients get SLAC wrist and some don't. But there's been a lot of sort of serial ligament sectioning studies done where if you cut just the scapholunate ligament, you actually don't get scapholunate dissociation. So there's a whole lot of secondary ligaments, the volar, radioscaphocapitate, radiolunate ligaments, then the dorsal intercarpal and dorsal radiocarpal. So it does take more than one ligament to cause the diastasis. And then the more ligaments that are cut, the more the instability, and probably the main thing is a high riding scaphoid, which will then lead to the arthritis. So treatment, you can start off with conservative treatment, brace, analgesia, activity modification, but be careful about this because these patients aren't going to get better with conservative management. So it's only for those patients who are very maybe old and low demand and don't want surgery. Or if it's a bad time for them to have surgery, maybe they need to delay it a few months, then you can consider conservative management, but their pain is not going to go away and they're not going to get better. So you either need to address the non-union or the ligament injury, or you go for a salvage procedure, which we'll go through. So really operative management is what you need to do with these patients. So stage 1 with SNAC and SLAC, basically, you do a radiostylodectomy and you treat the cause. So with a SNAC wrist, that would be addressing the scaphoid non-union with a orphan and bone graft, and you just do a stylodectomy. With this SLAC wrist, you do a scapholunate ligament reconstruction and do a radiostylodectomy. So the management of stage 1 is very similar. Stage 4, there's no option. The whole of the midcarpal joint and the whole of the radiocarpal joint are involved in arthritis. So there's no option for motion preserving procedure like a PRC or midcarpal fusion. So there you have to do either total fusion or a replacement. So stage 2 and 3 is where you can do these motion preserving procedures. They're still classified as like a salvage procedure, but you aim to retain one of the two joints in the wrist, either the midcarpal or the radiocarpal joint, and you can take away their pain but retain some of their motion. So midcarpal fusion, you can do this for the stage 2 and 3. You do get a primary midcarpal OA in some patients as well. It's quite rare, but it does happen, and you can also, so that would be another indication for this. So really what you do is you need to take away the scaphoid, and then to prevent the capitate and the distal row falling off towards the styloid, you need to fuse the midcarpal joint. So that's basically bridging the gap between the lunate and the capitate, and the hamate, and maybe the triquetrum, which we'll go through now. So these are all cases where you can do it. So SLAC stage 3, you can see here the capitate has started migrating proximally, and the capitate head is becoming arthritic against the lunate there. So that indicates that there's cartilage degeneration on the capitate head. So you can't have that articulating in the lunate fossa. So the option for PRC is gone in a SLAC stage 3. SNAC stage 2, you can also do a PRC or a midcarpal fusion for these. We'll get through the differences now. And then this is midcarpal OA. You can see the midcarpal joint is really quite destroyed, but the radiocarpal joint is maintained. So if you took away the scaphoid and fused the lunate to the capitate and those 4 bones there, or 3 bones, then they would do well. So you can do a 4-bone, a 3-bone, or a 2-bone fusion. Now, a lot of people just refer to this operation as a 4-corner fusion because a lot of people, and historically that was what everyone did, and most people still do now, is fusing the lunate, the capitate, the hamate, and the triquetrum. But we'll show you now, it's probably a better option to do a 3 or a 4 or a 2-bone fusion. So the 4-corner fusion, excise the scaphoid and fuse the other 4 bones together so that the distal row doesn't fall off the proximal row. Then your motion is retained through the radiolunate joint. The 3-corner fusion is you take away the scaphoid, but you also take away the triquetrum. So the advantage of the 3-corner fusion is that there's 1 less bone to fuse. And it's also been shown that you have better range of motion. It's not a lot, but it is a little bit more. And also, if you do need to put bone graft in that like in the lunocapitate joint, the triquetrum is a good source of bone graft. Often in these cases, the scaphoid may be a non-union and have had AVN, so it's often not very good bone. So it just saves you having to go to the iliac crest or the distal radius. Also, it unloads the ulnar side of the wrist, so you can get less ulnar-sided pain and less ulnar-carpal impaction. So I definitely recommend taking out the triquetrum when you do a midcarpal fusion, and this is what we always do that. So then, should you do a 2-bone or a 3-bone fusion? So you can see on the left, we just fused the lunate to the capitate. We left the hamate out, and on the right, we included the hamate. So it's really a call intraoperatively. Both cases, you're taking out the triquetrum and the scaphoid. And then I'll show you a picture a bit later of a type 1 and a type 2 lunate. The type 1 lunate has 1 articular facet and articulates only with the capitate. In that case, I definitely just do a 2-bone fusion. But in the type 2 lunate, where the lunate also articulates with the hamate, that's when you can consider doing a 3-bone fusion. So there's various fixation methods. The spider plate is really for the 4-corner fusion. But you'll see now they cause problems. They have some dorsal impingement. It's difficult to get compression, and we don't like them when we don't use them. But having said that, still probably most of the world will use the plate for that operation. We tend to prefer headless screws. We usually do a 2-bone fusion. Headless screws go in through the lunate, and the advantage is that there's no dorsal hardware, so you don't get the dorsal impingement and wrist extension that you do with the plates. And then the staples on the right, also good compression, but again, sometimes you can get dorsal impingement with wrist extension. So this is a very old X-ray. This is a bulky plate, wasn't a very good implant. You can see the problems here. On the left, there's non-union here. You can see lysis around that screw. So it's the bones haven't fused and it's getting loose. And that's just with the wrist in neutral. It's already impinging against the distal radius. So that's a problem with some of these older plates. The newer plates are a bit better. They're more low profile. The plate on the top right is a combination of locking and non-locking screws. So the non-locking screws can give you compression, and then you lock it with the locking screws. Some of them are radiolucent, so you can see if the bones fuse, but you can still get the problems. And as I say, we don't really use these, and we don't like them in our unit. All right, so coming on to proximal row carpectomy. This is where you take away the whole proximal row, the scaphoid, the lunate, and the triquetrum. And essentially what you have then is the capitate articulates with the lunate fossa, and that's where you retain your motion. So you need to have a normal capitate head and a normal lunate fossa. So it's really only the stage 2 in both of these, SNAC and SLAC wrist, where you can do this. In stage 3, the capitate has started migrating proximally and the head is arthritic, so you can't do it in stage 3 SNAC and SLAC. Also, you need the radioscapholunate ligament intact, which is the most important volar ligament. So in complex trauma or bad injuries, that ligament may have been injured and you may not be able to do this. So it's really the SNAC and SNAC stage 2, but also Cairn box is a good option, especially in the one with a coronal fracture. As the Cairn box gets more advanced, or in some other stages, you can get lunate fossa and capitate head involvement, but in some cases where they're not involved, the PRC is the best option to treat that. So which one should you do? If you've got a SLAC stage 2 or SNAC stage 2, this one on the left is a stage 2 SLAC, where the whole of the radioscaphoid joint is involved. So yeah, you could take away the whole PRC and the capitate head could articulate with the lunate fossa, or you could take away the scaphoid and fuse the capitate head to the lunate. So that's the midcarpal fusion, or you just do the PRC like that. So there's a lot of literature out there on it comparing the two. They're both good options, but there are slight differences. So both have very good pain relief. Patient satisfaction is generally a bit higher in the four-corner fusion. And the range of motion is slightly better in the proximal row carpectomy, and slightly better grip strength in the four-corner fusion. Complications are more in, well, the development of OA is more in the proximal row carpectomy, and that's because you've got the capitate head articulating with the lunate fossa, and it's not supposed to do that. They're pretty similar shape, but they're not exactly perfectly congruent. So you will, over time, generally get development of OA in that joint. Complications are a lot higher in the four-corner fusion. They're really all related to hardware. So you've got a lot of non-union dorsal impingement and hardware complications. Conversion to total wrist fusion, slightly higher in the PRC because of the higher development of arthritis. So as a general algorithm, what we do is PRC we do for lower demand patients. If a patient's a smoker, definitely go PRC. If the wrist is already very stiff and you do a midcarpal fusion, they may be even stiffer. So then you lose the whole benefits of doing this motion preserving procedure. So then you may opt for the PRC. It's obviously cheaper because there's no hardware. And it's slightly easier to do because you just take out the bones. You don't have to, it's quite difficult to do that midcarpal fusion at times. For the midcarpal fusion, we tend to do it in the younger patients who are going to live longer, less development of OA, and slightly better grip strength. So we do it for the manual laborers and the higher demand patients. So this is what I was talking about a type 1 and a type 2 lunate. On the left is the type 1 lunate. You can see the capitate head articulates only with the lunate and the hamate doesn't, whereas on the right side, you have the hamate articulating with the lunate as well. So it's almost like a knee joint on the right. And this may influence your decision to do the PRC as well, because on the left you can see it's a nice round capitate head, and that'll probably fit fairly nicely into this lunate fossa. Whereas in the type 2, sometimes you get this sort of pointed capitate head, and that probably won't fit that well into the lunate fossa. So in this case, you may prefer to do a midcarpal fusion if you have the choice. All right, so we'll go on to post-traumatic OA now. And this is really from malunited distal radius fractures, where you have intra-articular steps and intra-articular gaps. But having said that, it's very rare. So most distal radius fractures that have slight step or a gap, most of them do pretty well. They don't progress to symptomatic OA. They may have developed some radiological OA, but they often don't become symptomatic. So I think the upper limb is definitely a little bit more forgiving than the lower limb, because you're not weight bearing. So, you know, if you do have a slight step or gap, it doesn't mean that the patient's going to develop arthritis. It's often associated with scapholunate and TFCC tears, and occasionally carpal fractures as well. So treatment, conservative, obviously first, as in everything else in orthopedics. And then if it comes to operative, then you have the, you know, our goal with operations in the wrist usually is to retain motion. So if we have an option to do a partial fusion, then we do. And the one that we do for these usually is a radioscapholunate fusion. If that's not an option, then you can do a total wrist fusion or a total wrist replacement. So you need to assess which joints are involved to decide on which of these operations to do. You can usually we just use X-ray. MRI can be used in cases where you're not quite sure, and arthroscopy is also another option. So the radioscapholunate fusion is where you fuse the distal radius to the scaphoid and the lunate, and then you retain your motion through the midcarpal joint. So it used to have a really bad rap. And a study from 1997 showed 30% non-union, only half the patients were satisfied, and it had a higher conversion to total wrist fusion. But if you look in this picture here, they fuse the whole of the scaphoid and to the radius with the lunate. And the problem with this is when you radial deviate your wrist, the scaphoid flexes. And it does that because the distal scaphoid has to get out of the way of the distal row. So if you're fusing the scaphoid to the radius and you do that, then the scaphoid can't get out of the way, and then it completely disrupts your mechanics. And that's why they do so badly. And that will really jar on the radioscaphoid fusion if you're doing that. And that's why you get these very high non-union rates. So basically, really, people stopped doing this operation, but then we realized a bit better about the carpal kinematics. So then what we started doing was excising the distal scaphoid, and then it unlocks the midcarpal joint. So now in this scenario, if you radially deviate, the scaphoid doesn't have to get out of the way because the distal scaphoid is gone. So there's a lot less torque and toggle on that fusion, and now the results are a lot better. So range of motion is a lot better, and then the non-union rate has almost disappeared to 0% in Bain's study in 2018. He had a 15-year follow-up of about 20 patients, and they had a 0% non-union. And then again, similar to the midcarpal fusion, we take away the triquetrum as well, because it does improve the ulnar deviation slightly. Again, good source of bone graft if you need it, and it does unload the ulnar side of the wrist. So with this operation, you take away the distal half of the scaphoid, take away the triquetrum, and then you can do the fusion. And how do we do it? You can use staples, which is probably my choice. You can use a dorsal plate. I've used this only when it's really complex anatomy, when you've had very bad distal radius fracture, which have malunited, and you've got to sort of make a plan where the carpus is sometimes volarly subluxed and it's difficult to get the scaphoid, the staples in, and tend to use the plate. Some people use headless screws, but I don't know if that's enough fixation. And then K-wise, you can't compress with that, and it's probably not as stable. So I wouldn't do that. Do either the staples or the dorsal plate. So once you've got pan-carpal arthritis involving the midcarpal joint and the radiocarpal joint, then there's no limited wrist fusion option available. So then you look here at either a total wrist fusion or a total wrist replacement. So the fusion has been around for many years. It's the most favored procedure for this problem. It offers a permanent pain-free solution, but it does sacrifice motion, obviously. So it does result in slightly decreased function. But it is a preferred procedure and definitely more done around the world than the total wrist replacement, probably because people don't have the skill or don't know how to do the total wrist, or it's not available. Because the total wrist really is better for the lower demand patients. It retains a major range of motion. Patients are much happier with this than a total wrist fusion. And we tend to do this as much as we can. The only time we wouldn't really do it is if you've got a young patient or a manual laborer, someone who's really going to hammer that wrist and cause the replacement to loosen early. But if it's a relatively low demand, middle age or older person, then definitely the wrist replacement is our go-to operation for this. So the total wrist fusion, always through a dorsal approach. You can do it with either intramedullary or extramedullary fixation. The intramedullary is a Steiner pin, and we really only do that for rheumatoids with soft bone and poor soft tissue. The extramedullary is the better option with a plate and screws, which is stronger, more robust fixation. And that's what we do it for in a post-traumatic OA usually. Position of wrist is quite a talking point for this. Some people believe you should put it in slight extension, some neutral. But if you put in slight extension, it's good for grip strength, but certain tasks are more difficult. Certainly if you're going to do bilateral wrist fusions, you need to put one in slight extension, one in slight flexion. I mean, even going to the toilet is very difficult if you can't flex your wrist slightly. So that's the main reason for actually putting the one in slight flexion. So this is the dorsal plate. One on the left is quite an older plate where you had to pre-bend. The one on the right is, these come in pre-contoured plates now, locking screws, and they're good implants. You also get these newer plates which spare the third CMC joint. You can see how that's the third CMC joint there. And the reason is that you get a bit of give on the third CMC joint. So if patients put their hand down, it's not quite as rigid as the plates that go across to the third metacarpal, and patients tend to prefer this slightly. So we usually do this if it's available. Total wrist arthroplasty. There's been many implants out over the years. The two on the left was the Biax and the Maestro. Both of those have actually been taken off the market now because they had bad results in long-term reviews. The one on the top right is Freedom, the third generation, and the bottom right is the fourth generation, which is the only one of these four out on the market at the moment. You can see all of these have got an ellipsoid articulation, trying to sort of mimic the distal radius and the carpal row. But yeah, always the distal part is the one that fails. It loosens in the carpus. So we're still looking for the best implant. We use the Motec, and I think this is probably the best one out there at the moment. It's the only one that's gone for the ball and socket type of articulation as opposed to the ellipsoid. The distal screw goes through the capitate head up the third metacarpal shaft, and you have to make sure the screw goes past the isthmus and you get bite in the isthmus of the third metacarpal, otherwise they can loosen. The whole proximal row is removed, and then the radial screw down the middle of the radius, and then you have a cup and a ball. The cup comes in metal on metal. There's a metal on PEEK, which is the one in the screen, and they've just released a metal on poly as well now. All right, we'll just say a bit about inflammatory arthritis. So this is really rheumatoid, psoriasis, SLE, Angstbond, and a few others. So the features of rheumatoid, I mean, rheumatoid's a whole talk on its own, but the main features of the wrist that we see is, and it tends to do this in the progressive manner where you get bolus subluxation, in the carpus translocates ulnarly. So the whole carpus sort of shifts in that direction, and then as a result of that, whole hand deviates towards the radial side, and then you get supination of the carpus, which is where the ulnar side of the carpus drops down to the volar side, and sort of supinates the hand. That's the deformity you get in the wrist. And you get a kaput ulnar with the ulnar head subluxes that can cause a lot of tendon problems and ulnar-sided pain. And then you can get tenosynovitis from the rheumatoid itself, and that can result in tendon ruptures either from the synovitis or usually from the ulnar head, which subluxes and rubs on the tendon. Then you get MCP joint volar subluxation and ulnar deviation, and this is a difficult problem to sort out. It deviates ulnarly partly as a result of the carpus radially deviating, and the fingers go the opposite direction. So what are the issues with this? Very importantly, a lot of these patients, they have terrible x-rays. You look at these x-rays and the wrist is just destroyed. You can hardly see any joints and it's just a complete mess. But often these patients have no pain or very little pain, and they have excellent function. Often the fingers are subluxed, the MCP joints are dislocated, they've got spondylics and boutonnieres, and then they're very functional and they don't have pain. So it's very important that you must treat the patient here, not the x-ray. So you really have to figure out what the patient wants and needs, and only address the problems that they have. So if they only have ulnar-sided pain, you can address that. You don't have to go and replace the wrist, fuse the wrist, sort out the MCP joints. If it's not painful and they have good function, then it's often not necessary to treat it. They've also got soft bone and poor skin, so they do get complications with hardware and wound breakdown. So occasionally, if you see them sort of in the intermediate stage, that's when the carpus is subluxing or ulnar translocating and subluxing. If you identify this as happening, then you can do a Chamet fusion, which is an isolated radiolunate fusion, and that can arrest the carpal subluxation. But this is very rare that you actually get them at this stage and can identify it. So it's really not something that's going to happen very often. And again, these days with the disease-modifying agents, especially methotrexate, that really changed the natural history of rheumatoid. And it's really only old people now that we're seeing with these bad rheumatoid wrists. The young people get on these disease-modifying agents, and if that doesn't work, they go onto the biologics early, and then it really arrests the progression of this. So, in the future, we really aren't going to be seeing a lot of rheumatoids, and we're seeing a lot less now than we did 20 years ago. So really, in these late-stage rheumatoids, as I say, you don't have to address the wrist all the time. Most patients, I'd say, we actually only address the ulnar side of the wrist. So we do a mass resection or a Darix, potentially do tendon operations, and it's often that the radiocarpal joint is not painful. The way you assess it is pronation, supination. That assesses the ulnar side of the wrist, and most of them are painful with that, so you need to address the ulnar head. But only if they're really painful with flexion extension, then that's more the radiocarpal joint. So if they're not painful with wrist flexion and extension, then don't address the wrist. It's not painful, and if you fuse these wrists, that takes away a lot of their function. So only do it if you're sure that that is a source of the pain. Occasionally you can do a replacement, but as we were saying earlier, these patients have got soft bone, so it is quite risky. You can put in that metacarpal screw, and then it can break the metacarpal. These things can cut out. So I think use it with caution in rheumatoids. Most of the time we do the wrist replacements in osteoarthritis. Tenosynovitis we see a lot with the rheumatoids, and basically it's inflammation of the tendons, and it's the tendons that are run in the sheets in the extensor compartment, and quite often these are confused with ganglions, but they're different. They're not in the same place as ganglion. A ganglion arises usually from the scapholunate joint, so it's at the level of the styloid, whereas the tenosynovitis involves the whole of the tendon through the extensor retinaculum, so it often presents like a dumbbell-shaped things. So you have swelling proximal and distal to the retinaculum, because in the retinaculum it doesn't have space to expand like that. So you only see it the proximal and the distal ends. And then again, it tends to move with the fingers. So when the patients make a fist, the swelling moves distally. When they extend the fingers, it moves proximally. So with this, we address it at the same time as any other surgery. You do a tenosynovitis. Often these patients have ruptured their tendons on the ulnar side. You can see on the picture on the right, the ring and the little finger look like they've ruptured compared to the index in the middle. So you do tendon transfers, and then we do a retinacular rerouting where you do specific type of cuts to the retinaculum, and then you bring all the tendons superficial to that, and then you suture the retinaculum back to itself, deep to the tendons, which then can protect them from the ulnar head or the radiocarpal joint and prevent ruptures. But normally in these, you're excising the ulnar head anyway, but then the retinacular rerouting still protects it from the radiocarpal joint. As I said, the DRUJ is usually is a cause of pain in these rheumatoids, so you normally need to address that. Our operation of choice is a matched resection, which is just a variation of the DRUJ. I'm sure you've all heard of the DRUJ, and that's operation where you cut the ulnar more proximal to this picture on the left. The one problem with cutting with a DRUJ in any patient is that the ulnar head is often unstable, and with pronation, supination, that can impinge against the radius, and then that can cause quite a lot of problems down the line, and it's a very difficult problem to solve. So with a matched resection, you cut it more distally, and you cut it at an angle that matches the distal radius on that ulnar side, so that when they're still going to impinge as the DRUJ would, but your goal is to try and match the surfaces up so that it doesn't cause as many symptoms, and it definitely is better than doing a DRUJ. Suave Capongi isn't done very much now. That essentially is where you cut the ulnar just below the ulnar head, and then you fuse it to the distal radius. But again, here you still get impingement of this ulnar stump. And then this one on the right is a total replacement. That's a Shecker implant. It's not available in South Africa, and it costs about 150,000 Rand. But sometimes that's the only option you can do to salvage these unstable ulnar stumps. But as I say, we don't have it here. Okay, so a little bit on STT arthritis. It's very common, 2 to 16% of the population, and it's most common in postmenopausal women, just like CMC arthritis, and often the two go together. There's not many patients where you have isolated STT. It normally affects both sides of the trapezium. So these patients present with radial-sided wrist pain. It's usually around the palmar aspects of the thenar eminence. So it's just sort of a little bit distal to the styloid. You feel the scaphoid tubercle on the volar side, and it's just distal to that scaphoid tubercle where they present with pain. A good test for pain with the STT arthritis is forced radial deviation of the wrist, and then you flex and extend the wrist when you force the wrist into maximal radial deviation, and they complain of pain on the radial side around the STT joint. Quite often these patients present with FCR tendonitis or even rupture. So the arthritis itself might not be symptomatic, but the FCR tendon runs over the STT joint and inserts on the base of the second. So with the STT arthritis, you can get sort of osteophytes or prominence of the joint, and then that rubs on the SCR tendon as it passes over it. And sometimes the first presentation of this condition is where the tendon ruptures. But often once the FCR is ruptured, that actually sorts out the pain. And then you don't really need to do anything. They still have an ulnar extensor, and generally their pain is cured once it ruptures. But it's always something to look out for if you have FCR problems, especially in an older person. So again, you can start off with conservative management. Cortisone injections help. It's a very difficult joint to get into. It's very small and it's quite deep. But even if you just inject around the area, it tends to help. You can splint them, and then obviously activity modification. Once conservative management fails, you're looking at surgery. And if the CMC joint is involved, so that's the trapezio-metacarpal joint, then the treatment is easy. You've got arthritis both sides of the trapezium. So there we do the trapeziectomy, and we do a tendon interposition, which is our Birds and Pellegrini operation. Various options for that using FCR, APB. There's all different types, but that's pretty simple treatment. If the CMC joint isn't involved, like that X-ray on the left, you can see the scaphoid, trapezium, trapezoid, STT arthritis there, but the CMC joint looks good. So yeah, this is probably one of the better options, although it is a difficult condition to treat this. But basically, it's an excision arthroplasty where you excise the distal scaphoid and you do a tendon into position. This one here that's most people do is using an FCR tendon, where you wrap it up and you fix it in there. Some people put a spacer, but we're not fans of these, and they tend to sort of dislocate and they can erode the adjacent bone. So we've never done that. And then if you've got a younger, more higher demand patient, then you can do a SCT fusion. It's a hard joint to get to fuse. As we said earlier, when you radially deviate the wrist, the scaphoid needs to flex. So you have to really get good immobilization. And traditionally, it's always been done with KYs. You need a lot of KYs in there, bone graft, and you have to fuse the scaphoid in a perfectly neutral position. To do this, the newer implants now, you can actually get specific, like that 4-corner fusion plate. You actually get ones that are specifically designed for the STT joint, which are probably better because these KYs need to be removed. But still, it's a difficult joint to get to fuse. It's got a high non-union rate because any radial deviation is really putting a lot of force on that fusion joint. But if you've got a young, high demand patient, you don't want to do the interposition arthroplasty because it's not a great option for that. If it's an older, lower demand patient, then that's fine. All right, so that's everything. Any questions, guys?
Is dead space management ever an issue when you're excising multiple carpal bones?
No, it's I mean, they obviously bleed a little bit in there, but I've never had to go and excise or drain a hematoma or anything like that. So no, it's not a problem, mate.
Thanks.
And it's probably quite a simple question, but if you are dealing with a SNAC or a SLAC, should you rather towards over-diagnosing, over-coding it, if it's, let's say, kind of between a 2 and a 3, or between a 1 and a 2 in terms of your management? Okay.
Yeah, so that's a good question, So if you speak to guys in like Australia and America and that, then those patients, they'll get MRIs. I may even get just a diagnostic wrist scope to look at the cartilage surfaces to see what stage they're at, especially if you considering, differentiating between stage 1 and 2 is important, because the stage 1 is basically styloidectomy and fix the problem. So then you're going to fix a scaphoid or do a scapholunate reconstruction. So you've got to be sure that there is no arthritis. It's not stage 2, which would then preclude that. So they say that you need to do that so that you can fully inform the patient and they can make an informed decision, and then you blah, blah, blah. But really what we do is you go in being prepared to do all the options. So if you're going in to do address the stage 1, you must have whatever is available to do a stage 2, which is, you can always fall back on a proximal carpectomy, which you don't need any extra equipment. But if you are considering doing a midcarpal fusion, then you must have the headless screws there, which you probably have anyway with if you're addressing the scaphoid non-union. But if you're going in to do a scapholunate reconstruction, and then you go in and then you actually see that there's now the whole of the scaphoid fossa involved, which is a stage 2 SLAC, or if there's arthritis in the capitate head, which is stage 2 SNAC, then that then precludes you from doing the reconstruction. So then you'd have to bail out and do the either the PRC or the midcarpal fusion. And also if you think it's a stage 2 and it's an older low demand patient, and that's probably a good option for PRC, you must still go in and have headless screws or something available to do a midcarpal fusion, because if you go in there and you see the capitate head is now arthritic or the lunate fossa doesn't look good, then you're not going to go ahead with the PRC. So you need to have that backup of doing the midcarpal fusion intra-op. So always be prepared for it being a little bit worse. So that's our approach, rather than doing an MRI, waiting months, spending 10,000 Rand in private to get an MRI, whereas you can just tell the patient, listen, we're going to go in, we plan to do this, but we may have to bail and change our plan at the last minute.
All right, cool, thanks.